Sarah, can you see my screen okay now?
Awesome. We can see your screen. Yep, that looks great.
Okay, perfect. So it's certainly my pleasure to be with you all this morning. Thank you for having me. So for those of you who I may not have had the chance to meet before, my name is Krish Patel, and the director of the Hematology and Cellular Therapy program at the Swedish Cancer Institute in Seattle. And I am a lymphoma specialist, but over the last few years have developed a particular interest in the use of immunotherapies in the treatment of lymphomas, but as well other blood cancers. So I'm going to talk to you a little bit today about what is happening in the field of clinical research in lymphomas to sort of highlight, I think, some important themes that are applicable in all of oncology. So these are my disclosures. So we're certainly familiar with the use of immunotherapies in oncology and also in lymphomas. So if we think about treatments that have really existed now for some time in the management of non-Hodgkin's lymphomas, we have the very first monoclonal antibody to be used in oncology, an anti-CD20 antibody called rituximab. And as you all know, cancers, including lymphomas, often express specific cell surface molecules like CD20, and we can target these cell surface molecules with monoclonal antibodies. And rituximab now has been used for almost 3 decades, and really in the care of patients with lymphoma has been really paradigm defining and in oncology as well. So really the idea that we can use antibody-based treatments against cancers. We have a class of medicines we use commonly in hematologic malignancies, including lymphomas, what we call IMiDs or immunomodulatory therapies like lenalidomide. And these are derivatives of thalidomide, a very old drug, but really have a number of unique and interesting properties in which these medicines can have multiple impacts on the immune microenvironment in which a tumor cell lives, and ultimately help tilt the immune microenvironment towards one that is that has anti-cancer activity or is less favorable for malignant cells, including lymphomas. And then most recently, in the last, say, 5 to 6 years, the development of chimeric antigen receptor T cells, or so-called CAR T cells, in which we can take a T cell from a patient, genetically modify that T cell to be able to essentially find and hunt cancer cells in the body by providing them specificity to a tumor antigen. And these T cells can also make copies of themselves, so they become really a living therapy in the patient. So immunotherapies in non-Hodgkin's lymphoma have been used for quite some time now. But importantly, like all therapies, they do have some limitations. And one of the major limitations in the use of antibodies is we really have very limited data that tells us about whether we should continue to give antibody therapies in subsequent lines. We use them commonly in frontline therapy for a variety of lymphomas, and it's relatively common practice to give the antibody repetitively, even if we might change the backbone of therapy, but we really don't know that this is actually effective. IMiDs, while they certainly have a lot of different potential mechanisms of action, how much efficacy we get from an IMiD varies a lot by histology in lymphomas. And CAR T-cell therapy, for all its, I think, really sophistication and demonstration of the utility of gene engineering, is still, even to this day, a relatively challenging or cumbersome therapy to deliver. And there are issues related to patient access, the time to infusion, and toxicities that we see with current generation chimeric antigen receptor T cells. So all of that means there's a substantial opportunity to try to improve how we use the immune system to try to attack cancers, and that is certainly true in lymphomas. I put this slide here just to show how complex the immune microenvironment is. So we talk about this a lot in a variety of different oncologic diseases, the reality is the interaction of the immune system with a malignant cell, including in lymphomas, is quite complicated. So we have multiple subsets of T cells. We have natural killer cells. We have monocyte populations that can actually look quite different. Some that are tumor suppressive, some that are tumor supporting. And so the microenvironment plays a very, very important role in how an immunotherapy might ultimately actually be used to treat a patient. And we can see this if we look at outcomes in patients who have been treated with CAR T cells with diffuse large B-cell lymphoma, where we actually, if we were to just look at in a simple way, the number of immunosuppressive immune cells present in the microenvironment, specifically myeloid-derived suppressor cells, and we can see that the more of these immunosuppressive myeloid-derived suppressor cells there are in the tumor microenvironment, which is shown on the graph on the right, the less likely patients are to have durable responses. And so we really want to try to target specific parts of the immune microenvironment to augment the activity of immunotherapies in cancers, including in lymphomas. And so what might be some of those targets? So I mentioned that macrophage activity is an important part of the tumor microenvironment. So we can potentially develop therapies that modulate the function of macrophages. We may develop treatments that augment native T cell activity or natural killer cell activity. And so I'm going to talk about several clinical trials that we have been working on at SCI, and that really, I think, demonstrate and highlight these principles well. So what does the future of immunotherapy in non-Hodgkin's lymphomas look like? Well, I think, before we really think about what might be therapies that we want to develop, it always helps us to sort of take a step back and think about what are the qualities of those therapies that we want? So, in general, we would want any new treatments we develop to augment the existing immunotherapies that we have. We would want therapies, of course, that might minimize the toxicities of current generation immunotherapies. And I think this bottom point here is a really important one. We really want to be able to give these therapies right away to patients. Many patients with lymphomas, especially those with aggressive lymphomas, tend to be quite acutely ill at the time of either initial presentation or at the time of relapse. And so we don't often have a lot of time to be able to intervene for these patients, and we really need to be able to give rapidly available therapies. So the ideal cell-based immunotherapy might be one that is immunomodulatory. It complements the existing immunotherapies we have, perhaps improves their activity in patients that have very suppressive tumor microenvironments, or it might be an adoptive cell therapy. So again, an engineered cell therapy that really kind of marries all of these principles. And so there are several classes of therapies that are being studied in non-Hodgkin's lymphomas in early stage clinical trials that I think do really sort of speak to these properties. And so we at SCI have worked with all of these classes of therapies. And I think, again, while they're still early in development, there is a lot of great excitement and proof of principle from these early studies. So in broad categories, we can look at other immune cells beyond T cells that are harvested from the patient. So natural killer cells are present in small quantities in our body and are relatively difficult to collect from patients in an autologous fashion, but we might be able to use allogeneic natural killer cells. There are populations of other T cells different from what are typically used to make CAR T cells. So we can use these kind of specialized T cells called gamma delta T cells, and they may offer us some advantages over the existing T cells we use, in particular, the types of tissues that they penetrate into and the types of toxicities that we see. And we have a class of therapies that now is starting to find its way into the clinic. So we had our very first bispecific antibody in multiple myeloma approved in late 2022, and then another bispecific antibody approved for the use in follicular lymphoma And so these bispecific antibodies are an interesting way to perhaps use T cells that are present in the patient's body without having to take them out and manipulate them in any way. Antibodies are therapies that we can give relatively rapidly to patients in the so-called off-the-shelf manner. And if we are giving therapies that sort of stimulate the immune system, we can perhaps modulate some of the toxicities that come from doing so by adapting the dosing interval or the dosing schedules. And then the last class of therapies, I think, is in particular very interesting across oncology, so-called macrophage checkpoint inhibitors. So we're certainly aware that the immune system is capable of killing tumor cells, but at times the immune system is perhaps ignoring those. And a good example of that kind of balance is, I think, evidenced by the proliferation of so-called PD-1 inhibitors. PD-1 and PD-1 ligand are important in T cell and tumor interactions, but we find similar types of checkpoints on other immune cells like macrophages, and in particular, something called CD47, which is a don't eat me signal. So we'll talk a little bit about all three of these classes just to, again, highlight what is some of the, I think, exciting and promising work happening in the world of lymphomas that may ultimately have translations for all of oncology. So I've listed here some of the clinical trials that we are involved in particular those that incorporate these types of therapies. So we have a number of different allogeneic cellular therapies in lymphomas in trials at SCI, and that can include allogeneic CAR T cells, natural killer cells that are derived from pluripotent stem cells, and then so-called allogeneic gamma delta CAR T cells. They may all have different tumor targets. So CD19 and CD20 are the most common. Those are B cell antigens and expressed on all B cell lymphomas. The bispecific antibodies, the main class that we use in lymphomas, are CD20 bispecific antibodies. So they target CD20 on the malignant B cell and CD3 on the native T cell. There's several of them that are being studied, and now one that is recently FDA approved in follicular lymphoma. And then in terms of anti-47 targeting, macrophage checkpoint inhibitors, several different ways to do this as well. So I'm going to walk through a couple of these examples and really try to highlight again what the excitement and the promise is. But before I do that, I do want to just take a step back and say, especially if we think about the most recent immunotherapy that we have developed, autologous CAR T cells, what have we learned from that experience and how can that help us in further pushing the field forward? So when we think about patients, especially those with relapse refractory lymphomas who might be eligible for an autologous CAR T cell, so this living T cell based therapy made from the patient's own immune cells, ultimately the number of patients who might benefit from these is relatively large. But unfortunately, only a fraction of patients ultimately receive these therapies. And why is that? Well, certainly there is some stepwise drop off from patients who might be eligible to those who are ultimately evaluated in centers who are able to give autologous CAR T cells, and then a further drop off in those who actually receives the CAR T cell therapy. And why is that? Well, one area certainly that we still want to try to improve is the awareness and understanding of the availability of these therapies. So who are the patients with lymphomas who might benefit? There are still many patients who are never referred for this therapy. And so trying to understand, again, who is an appropriate patient to refer, what are the indications for autologous CAR T cell therapies is important. There are social barriers. So there are only about 140 CAR T cell therapy centers in the US. In the Pacific Northwest, there are only 4, 2 in the state of Washington. So the University of Washington and Seattle Cancer Institute. Swedish Cancer Institute, and then in Portland, Providence, Portland, and the Oregon Health Sciences University. So we see patients from a very large geography all around the Northwest, including Alaska, Hawaii, Montana, Idaho, the whole state of Washington, and parts of Oregon. And so sometimes for patients, the need to be able to travel to a specialty center limits their ability to receive this therapy. Even in patients who are ultimately seen for a consult or evaluated, we still see that there are issues that prevent patients from ultimately getting these therapies. One are medical comorbidities. So most patients with lymphomas are elderly and have comorbid illnesses. CAR T-cell therapies have certainly improved in terms of their toxicity profile over the last few years, but there are still some patients who ultimately will not be appropriate candidates. This number is getting, fortunately, smaller and smaller. Again, we might find social barriers. So to receive a CAR T-cell, patients often have to be tethered to the center that's delivering this for a period of 4 to 8 weeks, depending on the timing and what's going on. And so that can be a challenge again, including for those that might be not have support or caregivers or family that are able to provide the support that's needed as patients go through these therapies. And then the last are really, disease factors and external factors. Some patients with lymphomas have very, very rapidly progressive disease, and the disease kinetics themselves prevent them from being able to wait until the CAR T cells are manufactured. And then there are manufacturer limitations. So all autologous CAR T cells that are FDA approved are manufactured by partners in the pharmaceutical industry. And one of the things in the last year that has been a tremendous challenge is that the overwhelming demand for these therapies has not been really met by the manufacturer's capability to make these living cells. So there are waiting lists, unfortunately, in some diseases and at some centers like multiple myeloma, primarily because the companies that manufacture these CAR T cells don't have enough production capacity to meet the demand. So there are a number of different ways in which next generation immunotherapies might help to solve some of these issues. So this so-called autologous CAR T-cell dropout is a challenge. And really what I've just highlighted here, these are some of the pivotal clinical trials that have led to FDA approvals of CAR T-cells. And across all of these trials, in what we would think of as a very select population of patients, right? Clinical trials patients are usually very well. They tend to be well resourced. They tend to be well supported by family members. And so even in the best of circumstances where patients are eligible to enroll in a trial and able to enroll in a trial, see about 15% of patients who enrolled ultimately never get the CAR T cells. So this dropout is very, very real. And unfortunately, we see that manufacture fails or death prior to receipt of the CAR T cell is also something that occurs in patients in trials in about 3 to 4% of patients in pivotal clinical trials. So we would anticipate that this is much worse in the real world, where the patients that we treat may have more comorbidities, may be less well supported, and may ultimately look different than the population that received the therapies in clinical trials. Toxicity I mentioned is a challenge. So there are really two unique toxicities that we see in the use of autologous CAR T-cell therapies. The first one, called cytokine release syndrome, is really a short-term toxicity syndrome, but one that can be relatively intensive. So while perhaps a little bit of an oversimplification, it looks like induced sepsis, right? So we're taking immune cells that can stimulate the immune system and trying to use them to attack the lymphoma. See patients develop things like fevers, hypotension, sometimes even hypoxemia. Grade 3 or 4 CRS is the type of CRS that typically might need to be managed, at least for a short term, in an intensive care unit. And we can see that across CAR T trials, the rate of high-grade CRS is decreasing in more recent times, but for some products is still as high as about 20%. And this can be a real challenge in a population of patients with comorbidities or an older population. We also see, related to this immune stimulation, we see all these cytokines that can cause neurologic toxicity. And this neurologic toxicity is also, fortunately, temporary, but it also can be severe. And we see severe neurotoxicity in somewhere around 10 to 30% of patients. And again, this can be very challenging for older patients because while it may be reversible, the recovery takes some time. And the more severe the neurologic toxicity is, the longer typically the recovery period is for the patient. And then lastly, autologous CAR T cells are engineered to live and potentially persist in the patient for a long time. And that might sound like a great property in terms of disease and tumor control, but it also can result in some long-term toxicities. So autologous CAR T cells in lymphoma are engineered to target B cell markers, and they cannot really distinguish between normal B cells and the malignant B cells. So we can see B cell aplasia and prolonged hypogammaglobulinemia in a number of these therapies. And so that can certainly increase the risk of infections post-CAR T cell therapy, and ultimately the burden of management, especially for those patients who are having frequent or recurrent infections. So again, there are multiple opportunities to try to improve immunotherapies, and especially cellular immunotherapies. And I won't go through these all again, but summarized here, we want these cellular therapies to be rapid, broadly available, and reliable, right? So we need them to be able to be given to patients wherever the patients are, with ideally off-the-shelf therapies, so one that does not have any manufacturing time or lead time for the patient, but is like a drug already ready and for the patient. And we need those with less toxicity and improved efficacy. So allogeneic cellular therapy.
Dr. Patel? Hello, yes. Dr. Patel. Could you describe just briefly what are the clinical neurotoxicities in general? Yep. That's a pretty broad term. I wonder what those might be.
Yeah, absolutely. So neurologic toxicity from CAR T cells can be as simple as my thinking is a little slowed, but I'm able to do everything I need to do. I'm having the odd difficulty finding a word, so features of aphasia, but it's not impacting my function. To, in its severe form, temporarily patients can lose the ability to speak, to move, and for all intents and purposes, can look like they have a locked-in syndrome. And fortunately, that severe neurologic toxicity these days is quite rare, but it does still happen, and it can be quite scary for the patient and their family members. And so we assess patients every single day for the first 2 weeks post-CAR T cell infusion to assess for these types of neurologic symptoms using a standardized kind of toxicity assessment tool. It's a clinical kind of bedside assessment that incorporates really domains of attention, speech, ability to follow commands with executive function, and writing. And so most neurologic toxicity occurs in the first 4 weeks post-CAR T cell therapy, and then typically is resolving, but we can see more minor symptoms like my thinking is slowed. I have some still lingering difficulty with word finding out to about 8 weeks.
Thank you.
So allogeneic therapies really, I think, offer a potential solution to some of the challenges of autologous cellular therapies. So if we use healthy immune cells, either those that come from a healthy donor or those that are actually synthesized in the laboratory from stem cells, then we might be able to really circumvent the need to wait and the dependence on manufacturing of an individual patient's cells, which adds, roughly speaking, somewhere between 3 to 6 weeks to the process of treatment. And that's from the time we collect the cells from the patient until they get them reinfused. The number of slots to actually manufacture the cells may add further lead time. So if we can make these treatments ahead of time, that may actually improve our ability to use these therapies. I won't go into an in-depth discussion about issues related to allogeneic cell use, but suffice to say, when we're using immune cells that come from a healthy donor, there are different issues that we need to think about, and in particular are the potential for rejection, right? So the patient's own host immune system might reject allogeneic cells, and allogeneic T cells themselves may be capable of causing graft versus host disease, which itself can lead to substantial toxicity. So we need to edit out parts of the T cell that are really responsible for graft versus host disease, so the T cell receptor itself, and then potentially things that help it to evade the clearance by the patient's host system, like MHC class I cell surface proteins. We find that in using allogeneic cell therapies, we could use a CAR T cell, the same type of construct that we use for autologous therapies. We're really just using a different T cell from an allogeneic donor. We can use a very specialized population of T cells called gamma delta T cells. Gamma delta T cells have properties that are somewhat intermediate between T cells and natural killer cells. So gamma delta T cells don't actually have the ability to cause graft versus host disease, so we don't have to worry about that. And they may have different tissue distribution. So gamma delta T cells actually tend to distribute into places like visceral organs much better than alpha beta T cells. So in hematologic malignancies, that's not so much of an issue, but in solid tumor oncology, it certainly is. So gamma delta T cells may be a better cellular therapy for patients with solid organ cancers. And then finally, I mentioned earlier, we can use natural killer cells. We can insert CAR constructs in a natural killer cell. They work the same in a natural killer cell as they would in a T cell, but natural killer cells being part of the innate immune system also do not have the capability of causing graft versus host disease. So we may see less toxicity with other cell types. CTX110 is a CD19 allogeneic CAR T cell. This is being used in a clinical trial of patients with diffuse large B-cell lymphoma that we're participating in. It's a multi-center global study. And in essence, we use CRISPR technologies to edit healthy T cells and insert a CAR T cell. So all the patients in the trial who come in actually are receiving therapy almost right away after they've been screened and enrolled on the study, with very little delay from the time of identifying a need for treatment until they receive that treatment. For those who might be less familiar, I just put the schema here because this is common for all cell therapies. We give lymphodepleting chemotherapy partially to help create the right growth circumstances for these cellular treatments when they're infused into the patient. It's a single infusion, and then there's a period of follow-up where we're assessing for toxicity. And then within 30 days, we're assessing tumor response. With allogeneic cell therapies, we may be able to also give repeated therapies. So this is something we cannot do with autologous cellular therapies because of the complexities of manufacturing. And then this is just meant to show, as a proof of concept, that across different dose levels, we see that there is meaningful activity of these allogeneic cells, CTX110, and that the most recent dose levels that are being studied, we see overall response rates around 60% of patients, and complete responses, the type of response where all disease that might have been present on a PET scan is eradicated in around about 40% of patients. And these are numbers for context that are somewhat similar to what we see with autologous CAR T cells. Of course, the main and important question is, are there additional side effects? Interestingly, what we see is actually there may appear to be less. So we see less cytokine release syndrome, and generally speaking, no graft versus host disease and less neurologic toxicity. So again, an important proof of principle. Gamma delta CAR T cells are still very early in their development, so I won't talk about these in great detail, but just again to say that using a different immune cell may offer us multiple ways to attack the tumor. So gamma delta T cells do not cause graft versus host disease, so we don't actually have to take out the gamma delta TCR, and so we actually may have two ways in which the T cell is able to attack lymphoma cells, both through the use of its intrinsic immune receptors as well as the synthesized CAR receptor, which is introduced. And the toxicity profile, at least from very early study, seems to suggest, again, very low rates of CRS and the potential for outpatient use. Natural killer cells are slightly different in that we have to think a little bit more about the persistence of natural killer cells. So natural killer cells are relatively short-lived. They don't tend to persist over time. And so when we use an engineered natural killer cell, we may have to sort of either give repetitive doses, or we may have to think about engineering into the cell the ability for it to live longer term. So we can actually engineer things like cytokine receptors. So IL-15 supports the growth and expansion and persistence of natural killer cells. In addition to inserting a CAR, we can also engineer an IL-15 receptor that is chronically signaling that allows that immune cell to live and persist for a longer time. Natural killer cells also play a really important role in the response to antibody-based therapies. So we talked about antibodies in oncology as being an important and established mechanism of immuno-oncology and oncology, and natural killer cells bind to the Fc receptor of antibodies and are partly responsible for the anti-tumor effect of monoclonal antibodies. So we can actually enhance the anti-tumor activity of a natural killer cell by improving its ability to bind monoclonal antibodies, and we can actually modulate the tumor specificity of the natural killer cell simply by changing the antibody that we give it with. And so FT516 is an example of a natural killer cell-based therapy. This one, interestingly, does not have a CAR, but really relies on this high affinity CD16 receptor to bind a monoclonal antibody that we give with the therapy for its tumor specificity. So in this case, we use rituximab, a CD20 monoclonal antibody, to help target these engineered natural killer cells to the malignant B cells of interest. But we could change the antibody to change the specificity if we needed to. And so FT516 has been studied in a phase 1 study. Almost now close to 80 patients have been treated in the study. And the schema is similar. We give lymphodepleting chemotherapy. The natural killer cell can be given repeatedly, so it's given on a weekly basis. We do give some moderate dose of interleukin-2 support to help expand and activate the natural killer cells. Then again, there's an early disease response. And if patients are responding and tolerating the therapy well, they can go on to receive a subsequent cycle of the same treatment. And we presented these data originally at ASH, the International Hematology meeting in 2021. And what we saw in the initial presentation is all of the toxicity that was experienced by the patients is exclusively due to the lymphodepleting chemotherapy. There were no occurrences of cytokine release syndrome, no neurologic toxicity, no graft versus host disease. So the natural killer cells themselves seem not to have any specific toxicity, and all of the toxicity we saw seemed to be related to that lymphodepleting chemotherapy we give before the natural killer cell is infused. So did these therapies work? If we look in all patients who received at least a dose of 90 million cells, what we saw is, again, a response in 60% of the patients, complete responses in about 40% of the patients. And this therapy importantly worked whether patients had had a prior CAR T-cell therapy or not. So there were a number of patients in this study who had had prior autologous CAR T-cells and unfortunately had not responded or sustained a response to that CAR T-cell therapy. And so in this study, what we saw is that this therapy could even have activity in that very challenging patient population. Importantly, are these responses durable? At this time, the longest follow-up of any patient in the trial now is over 2 years. So there are patients in the study who have had 2 cycles of therapy, gone into a remission with aggressive lymphomas and not had a recurrence of their lymphomas. So the potential for durability. This is just an example of a patient of mine, a very young, unfortunate young man who had a so-called high-grade B-cell lymphoma with triple hit. These are extremely aggressive lymphomas that grow over days and weeks. He had had 7 prior lines of therapy, including 6 that included anti-CD20 containing therapy. He had been refractory to all of them, including he had received a FDA-approved CAR T-cell, in this case, Axi-cell, had a short duration of response to that CAR T-cell and then progressed. And at the time he enrolled in this study, had a very large, kind of bulky abdominal nodal conglomerate, as well as involvement around the bowel, shown in the baseline PET-CT here. After 1 month of therapy, which is 3 infusions of this natural killer cell therapy, this is what his PET scan looked like at day 29. That mass had entirely disappeared, and he remained in a complete response for almost up to a year, but then unfortunately died of COVID. but he was in a remission at the time that he passed. I won't go through all of this in detail, but we can then take that basic natural killer cell that I was talking about and add further genomic edits, like the insertion of a CAR T cell. This would then give the possibility for dual antigen targeting. So if we use a CAR that targets CD19, and then we still have the ability to give a monoclonal antibody to add some tumor specificity, we can target two antigens. Loss of antigen is one reason why patients might lose responsiveness to immunotherapy. So by targeting two, we may overcome that. And again, in this study of the natural killer cell-based therapy, we see patients who had complete responses that were durable. Another vignette shown here. This is not my patient, but a patient from another center that was treated, who again, within 29 days of therapy, had a substantial response to treatment with not much more than toxicities related to fludarabine and cyclophosphamide chemotherapy. So I'm just going to shift gears a bit here and talk about what about non-engineered therapies that help to work by using immune cells. So these are therapies that we give to the patient, and then the cellular portion of the mechanism of action is dependent on the patient's native in vivo immune cells. So bispecific antibodies are really a very clever feat of engineering. So when antibodies are naturally made, we basically have this kind of two symmetric protein chains that then fold and align with one another. And typically, monoclonal antibodies we use in therapeutically are what we would call bivalent but mono specific. And so both sides of the antibody binding domains bind the same antigen. Well, we can actually, through protein engineering, alter the way we do this so that one side of the antibody binds a specific antigen, like CD20, in this example, a tumor-specific antigen on B-cell lymphomas. And on the other side, we can use antibody binding domain that binds to an immune cell like CD3. And so we bring a healthy T cell, ideally in the patient's body, in close proximity to a tumor, and that leads to T cell activation and then T cell mediated immunity. We can also kind of vary, we can do lots of protein engineering with these bispecifics, and even do things like create a bispecific that has two binding domains for a tumor antigen and one for the T cell. So lots of very interesting formats of how we can create bispecific antibodies. So just as an example, glofitamab, which is probably the first bispecific antibody that will be FDA approved in diffuse large B-cell lymphoma, expected sometime in 2023, has been studied in patients in the third line of who have DLBCL, who had at least two prior therapies. This is a challenging population of patients to treat. And what we see is that if we give escalating doses of the bispecific antibody, we can mitigate cytokine release syndrome. So we do see cytokine release syndrome with these antibodies. That makes sense. They're still using T cells to try to fight the tumor. And then after we've kind of gone through that step-up dosing period, we can give the antibody infusion in less frequent intervals, like every 3 weeks or so. And in this study, the treatment was given for a fixed duration, for a maximum of 12 cycles. The types of patients that were enrolled in this trial, we participated in this trial, were very, very difficult to treat. These are patients that had had a median of 3 or more prior lines of therapy, and about a third of the patients in the trial had actually had previous CAR T-cell therapy. And patients who have progressed after CAR T-cell therapy, unfortunately, have very, very poor outcomes. The median overall survival in that setting is 3 to 4 months. And what we saw in the study is that across all the patients enrolled, 155 patients, the overall response rate in the study was about 52%, so a little more than half of patients responding to therapy. But more exciting than that was that 40% of the patients had complete metabolic responses. All of their tumor lesions on a PET-CT became metabolically cold. And very impressively, these were durable responses. We saw across different patient subgroups that the therapy would be beneficial, including in patients who had had a CAR T-cell. And this is the median duration of response as it was reported last summer at ASCO, a median duration of response of 18.4 months, and a median duration for the patients who achieved a complete response not yet achieved. I mentioned that survival, unfortunately, in the third line for DLBCL and especially post-CAR T-cell therapy is very poor. The median overall survival in the study was about 12 months. So an uncontrolled study, but compared to historical norms, a substantial improvement. And then if we look at the progression-free survival curve, there seems to be a plateau on this curve. And so certainly we are hopeful that some of these patients are cured. DLBCL is a curable disease, and so hopefully some patients will never have a relapse and long-term follow-up is ongoing. Glofitamab, as I mentioned, like other bispecific antibodies, can cause cytokine release syndrome. Different than cellular therapies or like CAR T-cells, we tend to see this as being perhaps mostly low-grade CRS, like a fever or transient changes in blood pressure. They tend to go away quite quickly. We don't seem to see neurologic changes at any substantial rate in patients receiving bispecifics. And then the cytokine release syndrome is typically predictable. We see this earliest in the first dose, and then we see a decrease with increasing dose. So this is the reason why doses are given in so-called step-up fashion, a small dose, a medium dose, and a big dose to try to mitigate the CRS. And then we see very little CRS thereafter, and these therapies can be given largely as an outpatient infusion. And so there are some lingering questions for this field as well. You know, what is the duration of therapy that's needed? In the disease we cure, we tend to see that all the patients who are likely to achieve a complete response achieve those responses in the first 2 to 4 months. So do we really need 12 months of therapy? For patients that ultimately do progress, why is that? What are the mechanisms of resistance? And then importantly here, we are relying on the health of the native T cells in the patient, right? We're not taking them out of the patient's body. We're not manipulating them in any way. There's no selection of the T cells. And so what is the impact of T cell fitness on outcomes? And are we able to actually measure whether patients that the health of the T cells that patients have already predicts for responses? And I mentioned again that, you know, duration of therapy is important. And this is just to show you that patients who achieve complete responses with bispecifics like glofitamab tend to achieve them very quickly within the first 2 to 4 months, and then they tend to be durable. And so the question begs, you know, are there better tests than, say, PET scans that are going to help us figure out who's truly in a potentially cured state or not? And of course, there's lots of work to use liquid tumor assays and things like what we call minimal residual disease assays to be able to use circulating tumor DNA to detect the presence of cancer cells below the detection threshold of imaging. Mechanisms of escape, this is still evolving, but we know that T cells can become exhausted. We know that tumor cells can lose the antigen that is being targeted by this bispecific antibody. And then I mentioned the microenvironment. So certainly in some patients, the inability to respond to treatments like CAR T cells or to bispecific antibodies might not be so much related to the immune cell that we're using to attack the lymphoma and the tumor itself, but the other immune cells that kind of protect the malignant cancer cells. And then I mentioned T cell fitness, and I put this here just to sort of highlight again what I think this means. So, you know, we all have many T cells in our body. We think of these as being quite healthy, but in patients who have had cancer, the interaction of the cancer cells with the T cell, the interaction of the immune microenvironment, the interactions of our treatments like chemotherapy, like radiation, all of these things probably lead to a dysfunction of those healthy T cells. So this is the setting in which we then are introducing an antibody trying to stimulate a dysfunctional T cell to attack a cancer. It is quite remarkable that these treatments even work in this setting. And so hopefully the idea is that if we are able to either combine our treatments with medicines that improve T cell health or give them in earlier lines of therapy, we will see potentially even improved outcomes. And so this is the focus now for the field using bispecific antibodies, is to combine them with other therapies that may improve T cell function and health, and that may also add targeting of other tumor antigens. And then lastly, I'll talk about this category of macrophage checkpoint inhibitors. So I mentioned that macrophages play an important role in killing tumor cells. So this is something that was discovered in the early 2000s at Stanford, and then corroborated by other groups. Tumor cells of all kinds express signals on their cell surface called eat me signals. So these are signals that macrophages can detect and say, this is an unhealthy cell, I need to eat this cell. However, tumor cells can also express something called a don't eat me signal, an inhibitory signal. And the most common don't eat me signal that has been characterized is a protein called CD47. So CD47 is expressed on a variety of tumor cells, solid organ cancers, as well as hematologic malignancies. And in essence, that don't eat me signal tells the macrophage, hey, even though you recognize I'm abnormal and you would normally eat me, just ignore me. And so we can target CD47 on tumor cells, or the receptor that it binds on macrophages, which is called SIRP-alpha, to try to restore the ability of a macrophage to eat a cancer cell. And we can see CD47 overexpression in a number of human cancers. So ovarian cancer was the first cancer in which this was described. But we also see some normal CD47 expression on normal cells, in particular on red blood cells and platelets. And so macrophages are also responsible for recycling old red blood cells and platelets. And so this is one of the toxicities of this class of therapies, is that some of these drugs do actually lead to temporary decreases in red blood cells or platelets. This is felt to be a recycling phenomena. So we're taking cells that would have been taken out of the circulation ultimately by the reticular endothelial system. We're sort of accelerating that. And so we see these transient cytopenias. But beyond that, we actually see very little toxicity. And so TTI 622 is an anti-CD47 targeting therapy that we've been helping to develop in clinical trials in lymphomas, both T-cell and B-cell lymphomas. And these data were presented about a year ago at ASH, where we presented safety data from a dose escalation cohort and initial efficacy. And just to say, these are mostly patients that had aggressive diseases. Most of the patients had had at least 3 prior lines of therapy. About half had had a prior stem cell transplant. About half had been treated previously with CAR T-cell therapy. So again, difficult to treat population. I mentioned that CD47 targeting agents may result in transient cytopenias, and we saw this as well. Interestingly, for this compound, we did not see much anemia, which is the most commonly described cytopenia, but we did see thrombocytopenia. And this tends to be relatively early in the first week or two, and then rapidly improves. That was the most common adverse event noted. You'll see that there are very few other adverse events of high grade. So this is a therapy that was actually very well tolerated by the patients on the study. As a monotherapy, we see modest activity. So about 26% of the patients responded, but some patients had very deep responses, including a patient of mine who had been treated with 6 prior lines of therapy that he had been refractory to, and that patient had been in an ongoing remission for over 2 years. This is an example of a patient in the study. Again, a patient with an aggressive lymphoma that had had 8 prior lines of therapy. This patient was treated at MD Anderson, so this is one of their patients. And the patient had had really bulky disease, and immediately prior to treatment had been treated with CAR T cells and then a checkpoint inhibitor, and had been refractory to both. And what we see here is that at week 8, there was decrease in the size and the avidity of the disease lesions. And interestingly, I think what makes this class of treatment so interesting is that there is probably more than one way in which this works. So certainly the ability of the macrophage to kill a tumor cell is part of it. But of course, then when macrophages eat tumor cells, they then become antigen-presenting cells. They present antigens from the tumor to the patient's immune system, which over time leads to an adaptive response from T cells. And so we see expansion of tumor-specific T cell clones. And over time, we see that the patient's own immune system is being primed or trained to attack the cancer cell. So, that brings me to the end, and I really just wanted to, end with some conclusions. I think immunotherapies have been a mainstay of cancer treatments, especially in non-Hodgkin's lymphoma, but there are some limitations to the current generation of immunotherapies we have. And I think what we all anticipate is that, the field of immuno-oncology is exploding, both in solid tumor malignancies as well as hematologic malignancies. And much of what we might see in the next 5 to 10 years, I think, really relates to trying to, in a more sophisticated way, target parts of the immune microenvironment, augment the function of certain immune cells that previously we were not really able to target, like macrophages and natural killer cells. And I'm very fortunate to be in a place where I have these types of trials to offer my patients, and really even now in phase 1 trials, we see patients benefiting from these therapies. So with that, I'm happy to take any questions.
Thank you very much, Dr. Patel. That was sort of amazing and sort of hopeful for this difficult group of patients. Does anybody online have any questions? Please unmute and ask a question if you have one. I have a question that's from 100,000 feet, and I'm a pulmonologist, not an oncologist, but we get these American Cancer Society deals once a year talking about the trends of cancer mortalities. Yeah. Prostate cancer, breast cancer, what's happened to mortality in certain solid tumors over the last 10 years or 5 years or whatever. So as a brushstroke, what has happened to the mortalities of lymphoma?
Yeah, good question. So in diffuse large B-cell lymphoma in particular, we see a decreasing mortality. 5-year mortality is decreasing in DLBCL, and that probably relates mostly to the development of rituximab in the 1990s, and then more recently CAR T cells. And so the 5-year overall survival now for patients with diffuse large B-cell lymphoma is somewhere close to 70%, whereas in 1998 it was around 40%.
Wow, great. Yeah. Well, if there aren't any other questions, again, thank you so much, Dr. Patel. Thank you, Sarah, for helping. And